My name is Akash Morality. I'm president of YMS. Also with me today are officers who you'll hear from a little later. So a little bit of background on the club. YMS is focused on providing high school students with an interest in medicine access to expert medical professionals. I'm particularly excited about our guest today, Ms. Hannapel, who is a registered nurse and infection preventionist working in a community health system in Florida, which includes 3 hospitals, urgent care centers, primary care centers, hospice care centers, home health agencies, and an employee health agency. She has over 20 years of experience in healthcare and for the last 8 years has been focused on infection prevention and control. Infection preventionists serve as a subject matter experts and advisors to both organizational leadership as well as bedside care teams. Additionally, they are responsible for developing, implementing, and evaluating policies, procedures, and plans relating to preventing and controlling infections, both among patients and employees throughout the entirety of the organization. Ms. Hannapel's experience is particularly relevant to the current pandemic and the rollout of the new COVID-19 vaccines in the United States. Now, Ms. Hannapel will provide some introductory remarks followed by a Q&A session for the members after. Ms. Hannapel, thank you for making time to join us today. Can you please start by telling us a little bit about your childhood, where you grew up, and what experiences made you want to initially pursue a career in medicine?
Well, I grew up for the most part in Chapel Hill, North Carolina, which is a hub of medicine. You're literally sandwiched in between UNC hospitals and Duke University hospital systems. Additionally, other trauma centers. I branched out. My family has always been in public service in one way or another, but usually government or school. But I found that I'm pretty much okay with how my garbage gets taken out as long as they come and get it, and I don't want to talk about it too much. But and that's something I just didn't have the patience for, but my father did. I found that I wanted to help people, and healthcare is a good way to be able to do that and serve my community. But also it has what I call self-limiting factors, meaning there were other things I wanted to do with my life. I wanted to be able to have a family and be able to kind of put work aside and go home and just be Lauren, the family person. And so going into nursing allowed me to kind of achieve both my work goals and my personal goals as an individual.
Thank you for that background. So now I'm going to invite some of the officers to pose some questions. And if each of you guys could introduce yourself by name and title and then proceed to ask your question. Akarsh, let's start with you.
Hi, Ms. Hannapel. My name is Akarsh, and I'm the website director here. And my question is, can you share how you chose to go into the career of infection prevention and some experiences that stood out as key learning moments going through nursing training?
So I have the kind of odd experience of I was recruited to come into this particular field. I've been kind of blessed. I'm kind of a fix-it person. So throughout my career, I pretty much started out as within 18 months of becoming a nurse, I became a charge nurse, and then was recruited into staff education. Then I asked to go into a leadership role within our radiology department. And while I was doing that, became a program coordinator. And I had done, I'd worked with our quality director at the time, and she basically just came and asked me. And I will admit freely at that time period, I thought that infection prevention was where nurses went to, get shoved out the back door. But things at that point were already evolving. So this is about 2012, where the role of infection prevention was becoming a key part of healthcare. We started, that was about when we started having to deal with the value-based purchasing program, which is part of our Medicare repayment system, as well as the HAC program through CMS. And that meant that hospitals were going to start being penalized for infections. So suddenly infection preventionists were very important. Became a big role. And having worked with that director on other program startups, she really wanted to bring me in and thought I would be a good fit. We were actually in the middle of an organism outbreak. So for the first 2 years, odds all I did was cluster investigations and outbreak prevention, which thankfully I can say now we did a very good job at that, and it's gone. But that's kind of how it was, sort of a happy accident, but it was something I was asked to do. I enjoy it because I learn something new every day. As far as training, my nursing training really helps me understand, obviously, transmission process. That's key, because you have to break that transmission process. And I'm sure we've all heard a lot about that with this pandemic, because it's all about stopping it before you get it or give it to somebody else. As far as like the key moments that I've kind of worked through, the bigger moments have been about communication and about listening. When you're in the role of infection prevention, you are literally sandwiched between the administration of a facility and the end-line staff of the facility. So your job is to communicate, here's what's happening to your administration, and here's what's happening to your inline staff, but at the same time work with the inline staff to try to create better processes. Nobody likes someone to come in, no matter what their role is. And by inline staff, I don't mean just nurses. We have to do this with physicians. So there's nothing, and I can tell you there's nothing physicians like more than being told how to practice medicine. They really love it. No. But one of the things that you have to do is you have to listen. You have to listen to their work processes and try to work with them. Here's the goal. Here's what we have to do to meet a standard. And here's what we have to do to do the right thing for the patient. How can we make it work in your workflow so we're not making your life hard? So I think the best things that I learned were just sitting back and listening to everybody, because everybody plays a part. It doesn't matter if you are working in laundry services, if you are working in environmental services, if you are the physician, if you are a nurse, if you're an occupational therapist, a physical therapist, everyone has a role in patient care. And it's important to make sure that you understand their role before you try to change their role. So that's probably the biggest things that I learned. I don't know if there's anything else you want me to add to that.
Yeah, thanks. Thank you.
Hi, Ms. Hannapel. My name is Ashley. I am the publicity director here at YMS. My question was, has your career been exactly what you expected? And have you faced any surprises that change your perception of the field?
Well, I can tell you that when I started out at 22, I didn't actually plan to do anything other than be a bedside nurse. I thought that was all I would ever want to do, was take care of patients. And I got bored. And so, no, it's not exactly what I expected. What I found that the turns that I've been able to make is I'm now more in a quality-driven role. So I get to shape how care is provided. And that's, to me, fun. I think the biggest surprises that I have are usually the things that I didn't think could possibly happen that do happen. They are the challenges that can occur to other staff, and they call you and go, here's what happened to me today. And you're like, oh, okay. And you have to figure that out. So that's sort of the fun part of what I do. But I think that I've just been very lucky in the sense that because I've worked for an organization for 20 years, that I've been able to develop and build relationships that have allowed me to grow and have allowed, people to think that, okay, let's pull her over here. We think she'd be good over here. So the path that I'm on is not the one that I envisioned 20 years ago, not even remotely, but I'm very happy with it. Healthcare is not what I thought it was going to be when I was younger. I was very, idealistic. I thought it was going to be all about just caring for people. And healthcare is not that. Healthcare is caring for people, and that should always be the center of what you're doing. But it is economics, it's politics, it's science, But there's also a faith component to it because you have to take that into account with every person that you're with, every patient that you take care of. So I think the idea, I thought I'd go in and I would just help people and not realize the impact that all those pieces can have on what we do every day in healthcare was probably the part that surprised me the most. The one that frustrates me the most is the politics. I admit that freely. I believe that science is science and we just leave, and medicine is a science. But unfortunately, because it's also economics, politics does get involved.
Thank you.
Hi, my name is Adrian. I'm the secretary of YMS, and I was wondering if you could tell us a little bit more about your typical day, what you do, what are your favorite parts, what are your least favorite parts, and so forth.
So right now, the typical day is a little different than it used to be, but some of it is exactly the same. I am fortunate. I work with 4 other teams. There's a team of 4 of us, plus a vice president that we work with. So every day, one of us actually has to come in and we have to look at every positive COVID patient that is admitted, everyone that has expired, and any that have come to the ED. And we actually pull together a daily report of all the positives. We have to have that done by a certain time. While we're doing that, we're looking at all the other reasons that we may put patients on isolation precautions. Whether it's because they have a multi-drug resistant organism in a wound, maybe it's in their respiratory tract, things that are not COVID, but still that we have to monitor and also isolate to make sure that we're not giving it to other patients or staff. So we actually review all those cases as well every day. Another part of our job is that we then have to take those reports. There's another list of organisms that's supplied by the state. We have to make sure that we report those to the state to let them know so that they can do their mandatory follow-ups. Some of those are things like sexually transmitted diseases, HIV, hepatitis C, hepatitis A. So we have to report all of those to the state. So that's part of like our typical, I call it the grunt work day. Then each of us has different roles that we play when we're looking for healthcare acquired infections. So currently I focus on surgical site infections. Previously, I was looking at central line associated bloodstream infections. So you start looking at those, and part of that job is communicating with where the patients were managed, so the unit managers for that, the physicians that were involved, and the administrators, and try to see, because we're at a point where you literally have to look at each case individually, and you basically do a many root cause analysis and try to work through, okay, what can we do better? What do we need to fix? What happened? Why? What may have contributed? So that's kind of the typical day. And then on top of that, we have to round. So we do go around and we look at the environment that our patients are cared for in. Sometimes it's based on just somewhere we haven't been in a while. We need to go take a look and see how everybody's doing. Sometimes we're looking at hand hygiene, making sure that people are following the appropriate isolation precautions. Sometimes it's just making sure the environment is what it should be: clean, non-cluttered, that people have the right tools that they need to keep things clean. Sometimes it's because we've heard something and we have to go check it out. Oddly, not in my nursing training, I spend a lot of time with our facilities operators and our engineers, and I've even crawled under the building because we do also have to involve ourselves in any construction, renovation, and repair to make sure that nothing travels outside areas that are being worked on, dust, that kind of thing that might contribute to any infections, both to employees and to patients. So that's kind of a typical day. What usually makes it go sideways is the random phone call of, hey, something happened. And that may throw the day off, but that's the typical day. It's a lot of data, it's a lot of review work, but then it's a lot of making sure that we have the right processes in place and that people are following the processes. So as far as what I like the most, I tend to like the things that pop up. Those are more fun. They're more challenging, and they get you out of the chair and out of the office. I don't think any of us in this particularly like the daily review, but it's how you find things, and it's just you have to work through the kind of that process to make sure that your processes are working. So the daily review of all the isolation patients is probably the thing I don't enjoy the most.
Hi, Ms. Hannapel. My name is Archie, and I'm the treasurer. And what have been the critical milestones in your career, and are there things you still want to achieve?
Well, let's see. I think one of the big milestones for me was actually the day I was asked by an administrator I had never met to be a charge nurse. And that sounds like a small thing in comparison to what I do now, but what it told me is that there were people paying attention to what I was doing more so than I thought. And that's important in healthcare. People need to know that the people are paying attention to what you're doing, because that's probably the thing you would hear, like the biggest complaint about amongst anybody who works in an acute care system is that, we don't get thank yous, we don't get pats on the back, we don't get any of that stuff. This is the job. So that was nice. The other one was being, I've been fortunate, like I said, I've had 3 roles here at this facility, including this one, where I haven't sought them, they've sought me. And with each one, my responsibility has grown. So that I appreciate. It also tells me that as a person and as a professional, I still continue to grow. And yes, there's still things I want to do. I am what my colleagues like to call the crazy lady. I really like regulatory compliance. And so really my ultimate goal one day is actually to work for when my kids are grown and I can travel more, and maybe not in the middle of the pandemic, to work for the Joint Commission, which is an accreditation agency. So that's really my ultimate final job goal.
All right, and another question is, what are some of the specific diseases that you have worked with, and what are the major breakthroughs in the field that you're looking forward to, and how would you like to see the field change in the coming years?
So I think the first organism I really had to work with a lot was multi-drug resistant Acinetobacter. And it was a carbapenem resistant organism, which means it was very resistant to pretty much one of the highest classes of antibiotics that we have. And in order to treat it, we were having to pull things off the shelf we hadn't used in 40 years. And that one was scary to me because it had about a 75% mortality rate. So it really killed people basically. We work with a lot of MRSA. I think that's probably the most common that people are used to hearing, or staph. People commonly get them confused. There's staph, which isn't resistant, and then there's MRSA, which is the resistant organism of it. The one I focus on now a lot and just kind of keep an eye on is what we call extended spectrum beta-lactamase organisms. These are organisms that can very easily turn into carbapenem resistant organisms. I feel like we're at a time in history, really, where we are going backwards instead of forwards. We are seeing people die of infection, not just viral infection, but bacterial infection. And it's not something that you expect in an antibiotic era, but we're getting to the point where we have what we call post-antibiotic era, where we've overused, overprescribed, not taken medications appropriately, especially antibiotics. And additionally, there's really no incentive for pharmaceutical companies to really study and develop and try to develop new antibiotics. And the reason for that is there's not money in it. If I get sick and I need an antibiotic, I take a 7 to 14-day course of antibiotic. If I have diabetes, I need to take something every day. And so the money is really in the daily maintenance medications, and that's what pharmacies really tend to focus on. So what I hope to see in the coming future is that not just in this country, but wherever, that someone finally says, look, we need to not let people die of things we were dying of, before penicillin was discovered. We need to go back to putting some kind of effort into antibiotic treatment and antibiotic research. And that's what I hope to see, that someone puts a foot down and says, in order to get the grant for this, you got to do this. You got to look at the antibiotics. So that's what I hope to see. I also hope that there is a company that is researching what's a universal flu vaccine. And I would love to see that happen. That would be great, because I think we're all tired. I mean, in a world where we're constantly, I feel like we're getting vaccinations, there's a lot of debate, even though as a science person, I don't think there should be. But it's okay. I would like to get it where, you know, we can come up with a universal flu vaccine that works for any strain that's created, because it really just slightly mutates, and that's how we end up with a different flu shot every year. But I think that we've done a good job with vaccines. We're getting better at it, which is why I trusted the COVID vaccine.
All right, thank you.
You're welcome.
Hi, Ms. Hannapel. My name is Rahul. I'm the VP. I had a couple questions for you. So my first question was, can you tell us about the impact COVID-19 has had on your work?
Oh, yeah. So it's been about a year since we started working on COVID. So my team, our primary initial responsibility when COVID first started, and this is back when it was still in Wuhan, was to basically monitor where it was at, what it was doing, and make sure that we had screening processes in place, that we also had an initial process in place for our system for that first patient that we might need to either screen or test. And then we ended up having to develop a task force. And I can't stress this enough when it comes to having, whether it's any emerging infectious disease, when you're developing a task force, whoever's the head of the task force needs to have the power. You don't want to have a task force where everybody comes up with a really good plan and then you have to go ask permission to initiate your plan. You need someone in the room who can just say, yes, do that. And they can write the checks and everything else. So I was really pleased that our chief operating officer just went ahead and said, I'm going to be it. And we went, yay. That made everything a lot easier. When we said we need to start buying supplies, because we knew there was going to be a problem. Because one, all of the supplies were made in China. That's part of it. That was the first thing we knew going ahead. We had problems during Chinese New Year's in the past. I said, this is going to be worse. So we were able to get our purchasing department on it. Our environmental services were able to go ahead and go, okay, we're going to need soap and sanitizer. So I think it's key whenever you have that task force, you initiate early, and that's what we did. I can tell you I looked like a zombie March, April, May. That was when our testing guidelines were constantly changing. In the state of Florida, for the first part of it, you had to actually have permission from the health department to test. And then your only other option was sending it out. There was no reimbursement for it. So you were also having to decide who really needed to be tested based on risk, because at that point in time, the numbers were low. Then it became who was important to test on-site when we got on-site testing versus who was sent out, because you only had so much supply for on-site testing. So we were on call at first for about 10 days at a time. And I came into work one day and I said, okay, I haven't slept in 5 days. Literally, my phone's been ringing off the hook. I'm having to talk through cases because doctors were literally having to call us and present cases to us like they were in their residency. So nothing like having that conversation at 3 o'clock in the morning. For the most part, they were really awesome about it, even though they were like, okay, I have to call and ask somebody permission to order a test, which is not their norm. So very difficult for them. But for the most part, every now and then we get someone who's grumpy. A lot of times we just got people who were scared, which was really sort of interesting to work with, because that was probably the biggest impact. I had what I consider to be reasonable, educated, highly educated individuals terrified of something they couldn't see, and they didn't know when it was coming or how it was going to show up into their lives. I literally had a phone conversation one time where it was the chief medical officer calling me going, Lauren, can you call this surgeon because he's living in his barn? And I went, why? Well, he heard a rumor he might have been in contact with, and at his home lived his small children and his elderly parents. And so he moved himself into his barn, and so we could sit there and talk over who he saw, where he'd been, what the rumor was he heard. And it took me a good hour to convince him he could go back home. He really had no risk at that point. I was like, we haven't had anybody, you're fine. Like, go home, go see your children. You don't have to wave at them from across the corral. But those months were hard. After we got testing guidelines normalized and we had a steady number of on-site rapid tests, and we do a lot of PCR testing here. We are fortunate we already had the equipment in our building, and we used PCR testing for other organisms. We were able to pull ourselves out of the who gets tested role and focus on data and actual patient care. So then we became the ones we were looking at, how are these patients being cared for? And we were working with our physician groups. We have an intensivist who just basically raised his hand and said, I'll take the lead. And our ED director said, I'll take the front line, you take the inpatient side. And we've all worked together to make sure we stay up to date on the best outcomes and then discuss what we're seeing. So now the role is more in an advisor capacity, back to our normal role versus being quite so in it and having to navigate it. But it's definitely changed our workflow. It's created a heavier amount of work on us, because in the midst of all this, on what we would normally do for any outbreak, cluster, or community transmission issue, each state, and y'all living in California, y'all probably have some of the most heavy regulations in healthcare. So I don't even want to imagine what your IPs have to go through, or your hospitals. I really don't. Every morning, there are reports we have to send to the state by 10 a.m. There are reports we have to get to the county by noon. And it's all data points. And part of it's monitoring how many patients you have, how many ventilators are you using, how many critical care beds do you have, and that kind of thing. And all of that is so they can assess their needs and what hospitals they really need to help versus, what hospitals are doing well during the pandemic. So yeah, that's probably been it's for the first 6 months, it's probably all we did. I think there was a 6-month period of time where we literally had to put aside everything we were doing and just do COVID. So we're kind of happy that that's not all we're doing anymore.
My next question was, do you have any rough estimates as to when everyone will have access to the vaccine?
Well, that's a tough question, because the Pfizer vaccine is approved, I think, for 17 and up. I'm not sure about Moderna. I think it's actually 18 and up. There haven't been any trials done at all on, or that have been published and peer reviewed at this point on persons under 18. So that's where I struggle. I don't know, even in what trials they've done so far, how many of what they did study were that 17, 18-year-old age group. So the student, the group is harder, because we just don't know when they're going to approve it to actually for you guys to have it. And then it's going to be harder because, what I hear on a regular basis, I was in the elevator today. I got my second shot today. So far, I'm fine. But I was on vacation when they started them. So, but I got my second shot today, and I was in the elevator, and a guy said, "No, I'm not doing it. I just won't. I'm scared of it." So it's very interesting, because as many people who want it, there's a whole subset of people who are afraid of it. So that's making rollout difficult, because it's hard to gauge who will have it. And as far as adults, because we're not set up on a national rollout system, yes, the CDC provided a basic guideline for how you should distribute. But it is not an enforcement agency. It is a science agency. It is a professional standards agency. But it doesn't have the ability to enforce, nor does it have the manpower to do so. Each state is then responsible for trying to figure out their rollout. And I'm beginning to think that, and this is sort of a joke at my own personal house, that my dad was right. We should have all contacted Jeff Bezos. We might have all had it in 2 days. Like prime delivery, because each state is struggling with the manpower to do it, because they're trying to make sure they have people trained to give the shot. They have to have the sub-zero freezers to maintain them. They have to be used in a certain amount of time. So it's hard to project. I can say that in our community, we already offer it to adults 55 and up that have comorbidities. We've also opened hours in our own facility to anybody who used to work here. If they're retired, they could come in. And they could have retired at 52. That's fine. If they worked 30 years and they retired, you were only 52, you worked here, you can get it. They offered it to all our auxiliary volunteers, and those actually span all age groups. The only ones they can't give it to, again, are minors. And that's because it's not covered by the EUA. So that's really hard. I don't have a good estimate for that. We bat it around in our office as a discussion, but it's really up to each state to make sure that it gets rolled out. I think everyone's a little disappointed. My parents live in Arizona. They finally just got, they're 77 and they just got theirs last Friday, their first shot. So I think in talking to people around the country, everyone's a little disappointed with how slow it's rolling out. So I think the expectations were a little high. We're set to be high and so, and a little unrealistic. So I think we'll have to be patient.
Yeah, you answered my next question too about vaccination in the workplace as well.
Okay.
And then my last question was, does the vaccine have any serious effects on like a certain demographic? So far?
What I tend to see, the people I worry about the most are diabetics. And simply because the immune response and some of the reactions we're seeing is very strong. And in diabetics, that tends to mean that their sugar spikes, their blood glucose spikes. And so that is probably if you're going to put a demographic or the comorbidity I tend to worry about the most. That I'm worried that we're going to see people coming in. The fortunate thing is that so far, we haven't seen anybody coming in with any issues. They've been able to kind of work with their primary cares on, okay, my blood sugar has gone up since I got the vaccine, and getting some temporary things to help manage for the few days that it seems to bother it. But that usually is apparently around like day 3 post the second vaccine or the second shot. So that's the group. The elderly are always at risk because you never know what's going to happen with their immune response. They could get altered just because that's the immune response is so strong. So that's the other, anyone over probably I would say 75 that has a bunch of comorbidities, I'd worry about them too.
So would it be like similar, like would they also like receive effects, like I'm talking like younger kids, like younger?
For the younger kids, because we here's the weird thing. So I oddly have a little more personal information. I have a 17-year-old and a 4-year-old. And oddly, in my family, when I was teaching them about coronavirus, my husband, who does not work in healthcare, said, he goes, well, we really have to worry about the 4-year-old. And I said, no, she could probably walk in and kill us all. She'd be the asymptomatic transmitter. More than likely, based on the way these vaccines have been developed, I don't think, based on what I've seen that's in the vaccines, they're very stripped down. There's really nothing extra, no preservatives. I don't think that the impact on kids and would be huge. I don't think it'd be any different than getting an MMR or a flu shot. But these are a little bit, they seem to have a stronger immune response because they're basically a new type of vaccine. And I think that's the concern that people have, is that, a lot of times we tend to think people who are young are healthy, and we really need to do a better job of screening to make sure we're giving it to people who can handle it. You don't want to give it to an immunocompromised patient that really isn't up to having a vaccine right now. You want to make sure that their, care physicians are comfortable with what the response would be, and that their body at that point in time can handle it. Just like any vaccine screening, really.
Okay, thank you, Ms. Hannapel.
You're welcome.
All right. So with that last question, we can now open it up to other questions from the membership if there are any. Go ahead and raise your hand and I can call on you and you can ask. Might be curious about.
If y'all don't have questions, I have questions.
Yeah, Rede.
Since you're on the hi, Ms. Hannapel, by the way, I'm a member. My name's Rede. So since you're on the front line, what do you think our approach should be to the next pandemic if we have one?
Well, it's funny. I actually talked about this with a state surveyor that came in one day, because he said, what's your emerging infectious disease plan? I'm like, oh, well, we threw that out the window. We had to rewrite it. Because we haven't had to have it. We've had a plan. Everybody had a plan, and no one ever had to implement it, because we really haven't had a pandemic since the Spanish flu. So I think, like I said, the best advice, when they asked me what I felt our facility did well, was I felt like as a health system, we did well with the structure of our task force. How often we met in the beginning, making sure that we were meeting appropriately, that we had the right people in the room to get the right things that we needed. Our engineer was able to create basically 70 beds for us to isolate patients. So we ended up being able to create 4 COVID units without ever really having to do anything more than change a little bit of the HVAC system in one area. Just because he sat down with us and said, what kind of isolation do you need? And we went, well, we'd like this. He went, okay. And 2 weeks later, we had extra beds. So it didn't even impact our regular census. So having the right people in a room when you're doing a response is key. I think also making sure that the people who are responding are calm, because the biggest thing I ran into, like I said, was fear. And it wasn't just the community members that were scared. It was your healthcare providers that were also scared. So you have to make sure you have people at the front lines that are not fearless, but just not scared, that here's the protection I'm supposed to use, here are the processes I'm supposed to use, I'm comfortable with them and I can implement them. And that really helps calm everybody else down. In the community, I think that the thing that we need to work on in general, this is probably a countrywide thing, not necessarily a where I live thing, communication and not raising the expectations so high that they can't be met, like I think we've done with the vaccine rollout. I think you have to be realistic. I mean, we knew a vaccine was coming, and you can have the best plan in the world, but you got how many millions of people who want it, and you have 2 companies making it. And they had to get approved before they started making huge batches. So the idea that they would have millions ready all at one time, and then a constant rollout of that was a bit unrealistic. So I think that the communication process has to improve.
All right, great. Thank you.
You're welcome.
Okay, next question, Yasmin.
Hi, Ms. Hannapel. My question is, are there any suggestions or pieces of advice that you can offer to those that plan to pursue a career in medicine, or any specific remarks you can offer to those interested in your particular field?
Okay. I think the best advice that I can offer as far as going into medicine or healthcare in general is make sure you do that self-evaluation of what kind of life do you want to have. There are parts of medicine where you could work 24 hours a day, 7 days a week, and never have a life outside of work. So you have to evaluate the kind of life you want to have. And that's really hard to do. A lot of times when we're talking to students, especially you guys' age, we go, what do you want to do? And we're talking about work. We don't ask the other questions like, what are your other goals outside of what you want to be when you grow up, so to speak. But I think as you move forward, you have to evaluate that. What else is going to be important to you? What you define as success, because it's more than just what you have in the bank or the house that you have. I think that as far as going into medicine, the biggest things that having gone to a large university that had a residency program, fellowship programs, I think the one thing that I always hear, the really experienced physicians talk about is I've watched some younger physicians and how they talk to others around them. And it ends up creating a more difficult workflow. So it's always good if you can respect the people you work around and the roles that they have and realize that that may not be the role that you have. And yes, they may need to do these things for you in order for you to do your job, but you have to respect what they're doing. And there's a way to do that. I think that's the biggest key piece, but also always keep an open mind, because there's a lot of you have to be open to the possibilities that it's not going to be what you think it is. And that's the other thing. I don't know how many times I've had a nurse come through the door and like 3 days later leave. And I went, what happened? And then when we talked later, well, it's not what I thought it was going to be. So we really try to work with our area nursing schools and talk to them about making sure that the expectations that their students have are realistic. And I know that I'm working with some of the physicians I work with that are also faculty at U of F and at FSU. They do the same thing. They try to give a realistic, here's what it is, so that when people are coming out and they're getting on their own or going into residencies, they're not surprised by what the job is. So really look at what you want to do and think about it. As far as infectious disease and infection prevention, it's a field that's going to continue to grow. I have I'm very fortunate. The ID physician I work with is from University of Florida, and he jokes with me all the time because we're the old people. We've been in healthcare the longest amongst the group that we work with directly most of the time. And he always looks at me and says, you can't teach an old doctor anything. And I said, you're an old doctor. And he says, yeah, but my job is to figure out what's new. That's my job. I'm an ID doc. And that's his joke, not mine. But his basic point is you've got to make sure that in the field of ID, you're constantly having to look at what's new and what's different. So it's a dynamic role that continuously changes. And I think that's something that draws people in. But I think it's something that people have to bear in mind when they go into it. It's not going to be where you get to create like a much of a habit. You're going to have to constantly learn and grow. And I've learned that from multiple ID docs I work with, that it's just, they have to be able to keep up constantly. And with a lot of medicines like that, but with some it's, if you're owning your own private practice and you're seeing a certain subset of patients, you can kind of get pulled into certain habits, whereas you really can't do that with ID. It's got to be a constant evolution. So.
Thank you.
Arya.
My question is, how many mutations of the virus have you guys dealt with?
Right now, I think what we're seeing is the second, like we're seeing the first and second variant. We're seeing the primary strain that initially came through, but we're starting to see, just talked about this with a member of our health department yesterday. We're starting to see more people coming in with the gastrointestinal concerns, including bleeding. So I think that's the second variant that we're seeing. So we're monitoring that because there are some complications with that particular strain that are a bit different than with the original that we were working with. The original seemed to be primary respiratory for those that were coming into the hospital. We've been pretty good about making sure you only get admitted if you really need to be. We didn't change our admission practices just to have people with COVID in here. So we were able to always have beds. But I've seen a few more, and in talking today, we started noticing that we were seeing more people with the GI problems and the GI bleeding. The bleeding is an issue because what happens is what we start to see is they have both a clotting and a bleeding issue, and that's very hard to control and manage.
And then one more question.
Mm-hmm.
So like, how effective is it, like with these different mutations, is the vaccine still as effective, or how does that work?
This vaccine is different in that there is not, so I guess I'll start with this. Your flu vaccines, the reason they change every year is they look at what's happening around the globe as it travels. And they put, usually it's quadrivalent. So usually there's 4 strains or 4 derivatives of the flu virus in there. Different ones, mostly they tend to be A because that's what adults tend to get. And usually they throw a B in there because that's what kids tend to get. And because it's alive, it's inactivated attenuated virus, meaning it's dead virus, basically. That's how your body reacts to it. The COVID vaccine doesn't work that way. The COVID vaccine actually isn't anything at all related to COVID. There isn't COVID in it. It actually works on how the body responds and it allows it to replicate and become virally active. And so it's a whole different ball of wax. And I think that's why we're seeing different reactions to it. Because it isn't like our other vaccines. It's a new ball game. It's very interesting. So the idea behind it being, though, that regardless of the variant, that it should be effective. think that's the goal.
All right, thank you.
Any other questions?
I have one.
Okay.
So, because I come from a place and where I'm pretty sure that we would call where I live the quarantine rules to be fairly slack. We're pretty open here, but you guys have been pretty much at home since when?
Since March of last year.
So you're going on almost 12 months at home. How, and anybody can answer, but one, how do you feel like it's impacted your education? And then how has it impacted you as individuals? Because this is a time where normally you're a time in development when you're normally very social. So how are y'all handling the impacts of that? And anybody can answer. I mean, it's just.
I think, okay, so I mean, I'll start, and then if anyone else wants to add, they can go ahead. Education wise, I'd say I don't think we learned as much as we probably would if we went to school.
Yeah.
To start things off. Because I think it's a lot harder to, like, for the teachers' points to get across to you when it's online versus in school.
Mm-hmm.
That's just my own opinion.
Is it harder to participate so that you have that interactive learning process?
Yeah, I would say so.
Yeah, I also agree with the college. Like when I'm in class, it's not as like my math teacher always says, like, if there was a whiteboard, you can actually show me the work properly, because lots of people have like image problems when they're turning in the work. The interactive aspect of it, it's like, I mean, you can always like talk with your friends, but I think this is like what everyone says now. It's that in Zoom everyone's like super silent, but then in actual like class everyone's louder, and that's what some teachers of mine miss. Just us,
Yeah.
actually talking more. But
So I do think y'all are kind of lucky. So I started thinking about what would happen if this had happened when I was in high school. And so, and Akash can verify this because his mom and I went to high school together. We didn't have cell phones. There was no way to hook your Xbox up. I don't even think there was Xbox back then. It was all just, I think, PlayStations and Nintendo. But you couldn't hook it up to the internet and talk to other people while you played. Like, they had to be in the room with you. So I think in some ways that I'm thinking, well, thank goodness it didn't happen when we were kids, because we would have been really, really isolated. We still had home phones that were hooked up to the wall. But even with all those technological advantages, do you still just miss being with your friends? Yeah. I mean, is it hard? I mean, and how do you handle that?
I would say at first it was pretty difficult with quarantine. Like, you couldn't go outside. Now it's like, I feel like now everyone's just used to it. Like, it's just become a way of life at this point. It's gonna be, like you said, it's almost gonna be 12 months. So now it's just everyone's starting to get used to it.
I feel really, it's, my daughter went through it from like March to September. And then, like I said, she went back to brick and mortar. She has to wear a mask all the time at school, which she's very good at. She's my kid, so my 4-year-old's good at it. But I noticed an immediate difference just in the change in her attitude in general. She was just happy to be around people. Like, she didn't care who they were. She didn't care if she even talked to them. She just wanted to be around people. So I was just wondering if there are different things that you do. Do you set up like kind of daily chats with your friends via Zoom so that you can see them?
I can take that one. So I wouldn't say it's via Zoom. We might like FaceTime occasionally, or hop on a Discord call and like play video games or something like that.
Okay.
I've noticed that like a way to interact with people, like at least for me, recently has been like going and biking with friends, socially distanced, obviously,
Mhm.
just like as a way to get out and get some fresh air.
Okay, so you are able to go. It's not like where y'all are shut down and can't go outside and do stuff.
Yeah, to some extent,
Yeah.
yes.
Okay. Well, that's good. No, I was curious because it is different than it is here. And I always wonder about that because I also, my parents, when they quarantined pretty much until we went out there. And I was starting to get worried about them because they were showing signs of depression. And so we actually went out there just to make sure they were doing okay. They live, like I said, they live in Arizona, and they sound a lot better. And we started showing them different ways to do things where they could be safe and be outside and see the world without getting COVID. So I think it's really important that you guys keep doing stuff like you said, like going outside and doing the biking and stuff like that. Because I think the biggest side effect of the coronavirus, besides people getting sick, has been depression. And its biggest impact has been on you guys, the students who are used to a certain amount of interaction every day, and it's also impacted your education. So I wish you guys, I hope that soon you'll be able to go back to school safely. That'll be the big one. If we can get some herd immunity, that'd be great.
I don't know if you have any information on this, but like at the latest, like at the very latest, when do you think will be when we go back to school? Like, do you think this could travel into our senior year, possibly?
That's what I worry about for the states where you guys are still not doing homeschooling. There are certain schools in Arizona that are the same way. My brother runs a high school out there, and his kids are still doing virtual school. What I'm hoping is that if we get enough either herd immunity settled, they'll let people come back to school, or if they feel confident in the reactions of one or the other of the vaccines, that they'll start doing some vaccinating of at least high school students. That's what I'm hoping. I can understand them not wanting to take a chance, with the younger kids, because you just really don't know how they're going to react to stuff sometimes. But I hope for you guys that you guys get to go back for your senior year. I really do. Because I think it's important, and I think it's important for so many different reasons. But the big one is the interaction with school. Y'all cited some of the things that my daughter said were really hard. It's hard to interact, and that was a big piece of learning. I'm hoping that we can get this vaccine rolled out enough so that you guys can get back to school by your senior year. I really do. And I think that's part of the push for everybody, because there's too many people at home, too many kids at home when they need to be in school. And I admittedly am not a good homeschool mom. I am not good at that. So they need to be ready soon, because my other one has to go to kindergarten.
Well, I remember at the beginning of the school year, they said like less than 10 cases per our county, because our county is different than other counties. And I don't think we're going to get to less than 10 cases anytime soon. So
like 10 cases total?
yeah, it was something like that, like less than 10 cases in the county.
Or
Now,
10%? 10%?
I remember it being cases. I can just look
Okay.
at the email again, but
Okay, yeah.
10% would sound better. But
Yeah, 10% would make more sense. I know that's a number that some of our accrediting agencies have used to determine whether or not they can send people in to do evaluations of facilities. So that's the number they look at. So I hope it's 10%, because you could have a nursing home outbreak and there's 10 cases.
yeah.
And that would have nothing to do with your school. So I hope it's just 10%. And that number actually makes sense to me. And we were fortunate in our county that we got down to like 3% at one point. So, but, and we had one little spike that went up right around the holidays. We kind of expected it, but it's starting to go back down again. So, but yeah, 10% would make sense. So I hope it's not 10 cases.
Yeah.
That'd be a lot. That'd be a lot to expect.
Are there any other questions from either Ms. Hannapel or
Sorry.
the rest of our participants? Okay. I don't think there is, so I think we can start to close this out. So I would just like to thank everyone for joining us today. Most importantly, thank you, Ms. Hannapel, for making the time in your busy schedule to give us a glimpse into the life as an infection preventionist. Our membership was particularly interested in your area of expertise given our current predicament, so we are honored to hear from you and benefit from your experience. Your career trajectory working in nursing and infection prevention shows a unique perspective in the medical field, and I know you have inspired many of us to learn more as well. So I would also like to express my appreciation for Mr. Chow, who unfortunately wasn't able to make it today. He is our advisor who has helped us launch this club and is supporting us on many fronts. And that should be it for now, everyone, and see you at the next club meeting. Thank you very
Thanks
much.
for having me.
Yeah.
Take
thank
care.
you. Yeah, you as well.
Thank you.
Thank you.